Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
One of the major drivers for many surgeons to pursue surgery is the idea that they can tangibly and physically cure someone of their disease. What is clear, however, once one starts surgical training is that often what we do as surgeons is guide someone through the end of their life and help them make the best choices for them. Dr. Melissa Red Hoffman is a dual board-certified palliative care physician and trauma surgeon in Chapel Hill, North Carolina. Dr. Hoffman spoke to us on this episode on her career, her writing, and her passion, palliative surgical care. Be sure to check out her own podcast, the Surgical Palliative Care Podcast. Links, as always, are in the show notes.
I was wondering out of the gate if you could tell us about where you grew up and what your training pathway was.
Sure thing. I grew up born in Brooklyn, raised in New Jersey. And for most of my life, I thought that I'd grow up and be a writer. And then after my father died, I got very interested in social work. So I thought I'd be a social worker and eventually kind of found my way to medicine. But my initial path in medicine was actually as a naturopathic physician. So I spent 5 years studying naturopathic medicine and got a naturopathic doctorate degree. And during my training, I actually spent some time in India in a truly integrative hospital studying homeopathy.
Wow.
Yeah, it was awesome. And that was the first time that I was in surgery. And, in India, it was crazy. I was in Mumbai and it was in this crazy hospital where the OR was like 100 degrees, like a burn OR, rather than the ORs we're used to where it's freezing all the time. And we wore flip-flops in the OR. And that was where I first saw my very first surgery. And I was really hooked. And I thought, oh my God, I think I've made a terrible mistake. I want to be a surgeon. And so I came back to the States. I finished naturopathic school. I actually worked as a medical assistant for 2 years for a surgeon, and then kind of started on the journey of allopathic medical school and surgical residency, and then more training in surgical critical care and hospice and palliative medicine. So I've been a student for the majority of my adult life is the end of that story.
Well, it's such a fantastic background, and clearly a lot of those influences still last to this day and make you the person that you are today. Certainly your passion for writing still persists, and it continues to permeate all the things that you do. And I had the pleasure to read one of your pieces recently in preparation for this, which was the JAMA piece, which was actually, for our listeners, voted as the top 40 pieces in the last over the last decade. Is that right? Yeah. And it's a beautiful piece that's called "The Sound of Silence When There Are No Words," and it's a moving piece where you talk about your father being killed by a terrorist in Egypt. Can you talk about how that early experience shaped your path through life?
Sure. It's funny. I was actually thinking of that piece the other day because I saw on Facebook that someone I know professionally suffered a horrible loss, and there were hundreds of comments, and so many of the comments were there are no words, and that was something that really touched me when I was going through this experience, though. I think at the beginning, there were no words that I had to express my feelings. So I was 19 years old, and, like many 19-year-old people, I was in a community that didn't necessarily know how to talk about their feelings. That's, challenging when you're a teenager or a young adult. And so I just struggled so much with what I was feeling on the inside. And that really, for me, ended up, I really ended up somaticizing a lot of my feelings. And that's really how I ended up going to naturopathic medical school. Was I was sick for years after my father died and found some relief through integrative medicine. Over the years, I really got interested in other people's suffering because I was noticing that my patients' families, so though I'm very tuned into my patients, I'm particularly tuned into my patients' families, were also like struggling as their family members were being sick or dying. They were struggling to find those words, and they were struggling to find someone to listen to them. And so I really got interested in holding space for those feelings or holding space for that silence. So that was certainly, I think my father's death just really, I think just one gave me a real appreciation for life, but really just gave me an appreciation for other people's sadness that I think I just never would have had. And I always feel so grateful. I'm one of those people that believes who knows why that happened? It was bad luck, bad timing, but there is a certain madness to the universe as well. And I really I feel blessed that I was able to take that experience and make the best out of it.
It takes so much courage to tell that story and to write that story and send it to a journal like JAMA. So I'm so impressed that you were able to do that and to express it so beautifully. And I wonder how much that sort of search for words and search for meaning has permeated what you do, because, in some senses, end of life care, which we're going to talk a lot about today on the podcast, and is clearly your life's work, is about kind of finding the words to communicate with people and to understand what gives them meaning in a really critical point in their life. Can you talk a little bit about that? Like, how has your journey as a writer perhaps helped you to become a better palliative care physician, and maybe vice versa?
That's a great question. Well, I think my experience as a writer, and I noticed one of your questions that I thought was really interesting is, how does that experience as a writer and that experience as a surgeon work as well? And I was reflecting on that. Sorry to steal your thunder if you were going to ask me that. But I was reflecting on how when I write, I love to just have silence and space in my head to let these ideas form. And so, I'll have this idea, and then over the next couple of days or a couple of weeks, it will slowly form in my head. And then finally I'll sit down and write it. And, that just kind of takes time and space. And so I love that idea of time and space, because time and space are really, I think, so important in the practice of good medicine. Of good palliative care, but really of good medicine. The idea of sitting down, where I work, there's a new tower in our hospital, and in every room there's a chair that's just kind of hooked up near the door that you can take. So there's always a chair, and I always use it to just sit down with the patients and their families and just to be quiet and listen, and to give them that time to think and breathe and cry and just be. So to me, the process of writing and the process of listening and the process of doctoring, they're in some ways all the same thing. The problem becomes, we're all so busy, and there's never enough time. And so you really have to be, or I have to be really thoughtful and mindful about how do I carve that out of a busy day. And sometimes that means staying late, or sometimes that means putting off those challenging visits until the end of the day when there's surgeries are done and all the paperwork's done, and then I can just go and sit with someone for a half an hour and not feel rushed.
That's a beautiful description, and probably something that we should all strive towards. Every day. There's no question we have to put the patient, I think, at the center of what we're doing always, and remember their experience. In some of those rushed moments certainly matters. If we shift gears a little bit, and I'd love to hear your thoughts on the emergence of palliative care and surgery in general. We both do trauma surgery, and I also do HPB surgery. And certainly there's not a day that goes by, I would say, despite discussing the process of dying or death that's just happened, or I wish I didn't have your skill set as a palliative care doc. How does one of those jobs inform the other, and how do you use it on a daily basis?
Well, one, I think a lot of people don't realize that, the term palliative care was actually coined by a surgeon, a Canadian surgeon, no less, Dr. Balfour-Mont, who was a urologic oncologist. So I always say that surgeons have like deep palliative care roots. And I don't think that many of us realize that. I think the other thing about surgery is we know that our patients suffer, even our patients who do well. I think being in the hospital and undergoing surgery or undergoing a stay in the ICU, there is so much suffering inherent in that. And I'll often tell patients, when the suffering is a means to an end, when it's going to lead to saving a life or improving a quality of life, that's great. The problem becomes when this suffering, I'll say, to what end? When the suffering is just never ending and the outcome is not what the patient or the family would have hoped for, then what do we do about it? And so for me, people have asked me, well, don't you get confused, like if you're wearing one hat or the other? But to me, a good surgeon, kind of stands by their patient in the preoperative period, in the operative period, obviously, and then that postoperative period, regardless of what it will bring, because that's kind of the covenant that we make with not only our patients, but with their families as well, that we are going to stand with you. And so again, while it takes a great amount of time sometimes, and a great amount of emotional energy that sometimes it's hard to kind of summon at the end of a long day, or especially at the end of a long day in the operating room, that's kind of the promise that I feel like we made with our patients. And while I think it's nice to have training in hospice and palliative medicine, I mean, there's 80 surgeons in the United States who are board certified in hospice and palliative medicine, but there are certainly hundreds of surgeons who I think do good primary palliative care with their patients, because it's just very patient-centered work that I really feel like anyone can do with just a little bit of training.
That's so interesting that there's 80 board certified sort of double boarded folks. That's remarkable. Probably the rest of us maybe don't use you folks as the 80 probably enough. I mean, I really think we could learn so much more from all of you.
And one thing that I always say is, like, the best way to learn is that when you are consulting the palliative care team, if you could just, I'll tell my trainees this a lot, like, go to the family meeting and watch what they do. Because for many years, my first introduction to palliative care was as a fourth year medical student at OHSU in Portland, Oregon. And then where I went to residency, we didn't have a palliative care team. And so the patients suffered greatly. And I did a lot of what would be considered primary palliative care, really just based on that month-long training and some of the reading that I've done. So I feel like there's a lot to learn just from watching other skilled communicators lead a family meeting, or have a goals of care discussion, or have a discussion about code status. And, you might not be perfect, but none of us are perfect, so it doesn't matter. I think if you are coming from a good place, I have found families to be, and patients to be, quite forgiving when your heart's in the right place.
We sort of dived right into the topic, which is your life's passion, and your clearly something that you're getting good at, and have made an objective of trying to spread it, which is palliative surgical care. And you actually mentioned, you have a great interview on your own podcast with Dr. Balfour-Mont on the origins of palliative care. But for our listeners, how would you define palliative surgical care, and
Sure.
What does that mean to you?
So I'm going to read the definition. And we call it surgical palliative care. And so this is the definition from Dr. Jeffrey Dunn. So while Dr. Balfour-Mont coined the term palliative care, and he's considered the father of palliative care or palliative medicine in North America, I call Dr. Jeffrey Dunn the father of surgical palliative care, because he really brought that idea of surgical palliative care to the masses starting in the late 1990s. And he defined surgical palliative care as the attention to suffering in all of its manifestations, so physical, emotional, psychosocial, and spiritual, of the patient and the family under surgical care. So a very simple definition. And basically what it means to me is that we are, as surgical palliative care providers, we're not interested in just the physical manifestations of pain and suffering, but we're really tuned into our patients and their families as people, and we're there to minister to them kind of throughout their surgical journey.
I love that definition. To be honest, I'd never heard it. One of the things you said that took me back was how we model ourselves, or how we actually deliver these conversations and engage in these conversations. And it's amazing, as a surgical trainee, to your point, watching different folks, whether it's an HPB surgeon, whether it's a formal palliative care expert, the different styles and the different deliveries with which you see, not only from clinician to clinician, but also really almost from patient to patient. And my observation, I remember thinking very early on of some of these really good communicators with that, as you'd expect now with so much experience, their ability to shift gears, almost even the cadence of their language could change depending on who they were talking to. Like it's really quite an artistic and beautiful skill.
Yeah, I will say, my experience as a palliative care fellow, that was one of the most challenging years of my life. I mean, after years of surgical training and then doing a surgical critical care fellowship, I was just feeling challenged in such a different way. The feedback was so much more personal, and in some ways so finely tuned into really that communication style. Like we would have discussions on, because I have a very loud voice, especially when I'm talking about something I'm excited about, how do we kind of lower the volume of our voice? One of my attendings used to say, be the smallest person in the room. This is not about you at all. I'd got a lot of feedback around, I tend to if I'm, my resting face is more like a resting smile face. That's just my face. And I remember some of the feedback I got was well, that smile is just really inappropriate during this hard family meeting. That was challenging. It's my face, right? But it did really make me, I just really appreciated all that. It was just that, I came in thinking oh, I'm so good at this. And then I realized, oh my God, I have so much to learn. And, I had several times where my program director, who was just so great, he would really say, I'm just sensing you're very surgical today, very rushed, and just how we are when we're rounding, we're just go. We got to get all this stuff done before 7:30. And he would just kind of tell me to slow it down. You don't have anywhere to go. You're not in a rush. And so, I would say today, I always think if my attendings from palliative care saw me, what would they think? Because really, I think I'm in many ways, I still act very much like a surgeon, because the majority of palliative care that I do is as a surgeon, my main job is a surgeon. And so I'm fitting this into my busy surgical day. But I still always do sit down. I'm a big fan of touching, I love to touch people's feet for some reason, but, either holding on to their hands or their feet, or sitting on their bed, making some sort of human contact, because I think, especially now in this last year, our patients are so lonely, they're so starved for physical connection, because they're not with their
totally.
families. Yeah. And so I think that's become even more important. And then just really trying to get the family on the speakerphone, and so they can be a part of the conversation as well, and be a part of a lot of this just difficult decision making.
Can you unpack for us a little bit more what was different about the training that you did in palliative care, and what did that teach you that was different than what you already do? You get the sense that a lot of surgeons now, I think, talk about palliative care and talk about end-of-life discussions, and really that's something that's part of our zeitgeist. I think of Atul Gawande's book, Being Mortal, and what that's done for the conversation both inside medicine and surgery and outside of it. Do you think like what were the things that you learned that you weren't expecting to learn, or the things that you just found that we weren't doing well? And what are the things that you think that surgeons in general could improve on?
So one thing I learned is like how to shut the blank up. And so, I think, I don't know if it's in Atul Gawande's book, or I've read somewhere, that like doctors tend to interrupt their patients within the first like 16 seconds or something. I really learned how to shut my mouth and just let the patients or families talk. Now that is something that takes time, right? So again, as busy surgeons, we don't always have that time. Sometimes as a palliative care provider, you'll leave an hour for the meeting. And so you really do have time for patients and families to just really get it out, however long, whether that's 5 minutes or 7 minutes, at some point they stop talking. But then I also learned the power of so not just like shutting the blank up, but that power of silence, because that silence can become very uncomfortable. But in that silence, then like the real emotions emerge. So just kind of sitting there, and then eventually they'll start talking more or start crying or start filling that space. So if I jump in and fill that space, then I'm really denying the patient or the family that opportunity to go deeper. So that was something that I hadn't really thought a lot about. We think about like listening and active listening, but really just like sitting in that deep, oftentimes very uncomfortable and awkward silence to see what comes up. And it is like, it's incredible what kind of bubbles up on the surface for people. And then I think I learned to ask a lot of good questions that tend to work for everybody, or in many situations. So one of the questions I love to ask is, if your family member was in this meeting with us right now, rather than like intubated and sedated in the ICU, what would they say? And so like inviting that patient and their spirit into the room, even if they're intubated and sedated in the ICU, it really is incredible, because people will just like shout out, they'd say like, get this off of me, or get me the hell out of here. Like it really gives a voice to that person. And so like, that's one of the tricks that I use to like get, families get so concerned that I'm not making the right decision. Well, really, we're inviting you to please speak on behalf of your loved one. What would they say if they were here? And sometimes the families don't want to hear what they would say, because the loved one would sometimes say, I don't want to do this. And the family member wants them to keep moving, because of course they're human and they don't want to lose their loved one. They don't want their loved one to die. But it's just, I love that question. I just get the most remarkable answers.
One of the things that I reflected on after reading Being Mortal, and actually Atul Gawande came to our class while I was doing my MPH in Boston. And one of the things, he's a fantastic guy and just a riveting person to listen to. But one of the things that I have wondered about, there are a couple of things. One is in true Gawande fashion, he came up with a checklist. And so I'm curious if you have a similar checklist that you use when you're actually trying to approach the situation, or is it much more fluid or organic, and you kind of try to tailor it, as Dr. Ball said, tailor it to the person that you're speaking with?
I think another thing I learned in my palliative care fellowship was really not to have an agenda. So if you're going into a meeting and you're like, I got to get a code status, I mean, a lot of times that's like doomed to fail. You know what I mean? Because there's many people who don't want to talk about that right now. And it's, certainly there's some times where it's, say a sick emergency general surgery patient in the middle of the night that has peritonitis and has to go to the operating room. I mean, that you kind of, I feel obligated, and I want to have that discussion right away. But, when we have time, if someone's like a trauma patient in the ICU, they're going to have this prolonged stay, and you can just kind of tell it's not going to end well, say. I don't always have to get a code status on the first go around. So kind of, for me, I try not to have an agenda, and I can tell. I can it's not like I always can manage that, because I am thinking recently I was in the trauma bait. And like, I had such an agenda. Not only did I want a coach status, like I wanted this family to make this person a do not resuscitate. I mean, like I really had strong feelings, but like, it's not, it's not about me. And I could tell that I was I was pushing it a little bit, and I could tell that the family member was really just kind of shutting down, and I honestly don't blame them. I mean, what do we get from that? Then we're never going to revisit the discussion. If I go in without an agenda, I bring it up, they shut me down. They don't want to talk about it right now. Well, I didn't burn any bridges. And then a day later, I can just kind of come back and talk some more and maybe revisit it, say, remember what we talked about. And so I really don't have, a checklist. I have certain questions that I always ask because I think they help me kind of get at who is this patient. I love asking, tell me about the last 6 months of so-and-so's life. What was it like? Because it's very easy for someone to say, oh, mom was doing fine. Well, what have the last 6 months been like? Tell me what a typical day's been like. And then you realize, mom hadn't gotten out of bed in weeks. Yeah, she's quote unquote fine, but she's really not doing anything at all. And so that kind of helps us establish like a baseline functional status, which I think is always good for, sometimes we're just kind of blind to our own suffering and to the suffering of those around us. So I think it's good to kind of have people say that and then reflect it back to them. Well, this is where mom is. And I mean, the reality is, we're probably never going to get her back to here. And after a long, prolonged hospitalization or a surgery or a trauma, I mean, the likelihood of even getting to 75% of that is sometimes, highly unlikely. So what would mom think of that? But again, no, I don't have a checklist.
Yeah, to me, that makes a lot of sense. The other thing that I have often struggled with, and Dr. Ball and I have had lots of discussions about this, is that, in some ways, what we're trying to do with these end-of-life discussions and palliative care is really have people confront a reality that we're not used to thinking about. And this is why I brought up your essay right at the beginning, is because I do think, in some ways, having to deal with, your own mortality or a close family member's mortality makes you think about this issue differently. But, one of the things that's so challenging about this is that we have to have this discussion about something that nobody wants to talk about, and none of us are really in touch with. It's not something that we think about. If you're to talk about, your end of life when you're healthy, people say, oh, well, that's kind of a morbid discussion, even though it's not really. It's sort of a way of embracing life in some ways, and a way of thinking and enjoying your own life to the fullest possible. Even if you're healthy. And it becomes even more important when you're really in a difficult situation. So I'm curious how your experience has been with trying to, in some ways, combat a cultural challenge, which is sort of endemic in the Western world and in modern reality.
So one thing that I do is, and I talked about this a little bit in my essay, but I think like the power of sharing stories is like pretty incredible. So, with my older patients, I'll always ask, are you married? And a lot of them are widowed. And so then I'll say, oh, how long were you married for? How old was your wife when she died? Was she sick? Like, I'll really inquire about that death. I mean, I always tell my patients, like, everyone has an expiration date. I mean, we're all going there. And so I just don't shy away from it, because people will often say, it is amazing when people are in the hospital. I don't know, I'm sure you guys have noticed this too, but it's like it brings up everyone's other deaths. So many family members will be like crying about, oh, my brother died last year, or my mother died 15 years ago. Like, it brings up all their stuff. And instead of ignoring it, I'll kind of dig into it a little bit. Well, oh my God, how old was your brother? What did he die from? Like, I'll often ask, like, do you dream about him? So kind of just like normalizing death in general. And then, it's hard to talk to a patient, especially a sick patient that, is, you get that sense, right? We all have that doctor sense that this patient really may die. It's hard to ask a patient, how they're feeling when they're so close to death. I have found that the majority of people, when you ask them, they have been thinking about their mortality. They might not be talking about it. They might not have like formed a lot of coherent thoughts. They might not have like the most graceful words, but you know, people know when time is short. It's quite remarkable. It's like the reality is though that we don't like hold any space for people to even talk about it. So, you know, when someone's sick, it's like so many families have said to me, God, I wish I had talked to mom about this, but I didn't want to hurt her feelings, or I didn't want to make her anxious. And, you know, meanwhile, I'm at mom's bedside and like, you know, the majority, not all of them. I mean, sometimes it's challenging when people are not really realizing how close they are to death, but the majority of people know, and yet we don't really invite them or hold space to talk about it. So I try to hold a lot of space and ask like very honest questions, like, do you feel scared, or what do you think happens? Or when I'm at a patient's bedside, you know, say when we're doing like a terminal extubation, I always ask the families, like, who's waiting for them on the other side, you know, to kind of like conjure up all the spirits in the room. And that is also a great question, because then they start talking about all their dead family members, and it brings a lot of joy and like love into the room, and really could feel all these spirits like just waiting to invite this patient to the, it sounds a little woo-woo, but I really do believe that, like, you know, just waiting to welcome this patient. I always tell our families, like, you know, they're just going out with a ton of love, and they're just going to be met with a ton of love. And so I just try to keep talking. Like, and that's where I have a hard time being quiet sometimes, but I just try to keep moving the conversation, keep normalizing everything. Like, yes, this person is dying. Yes, you're dying. Yes, we need to talk about this. And yes, all these other people have died, and we're just going to keep telling these stories and keep conjuring up these memories and keep kind of calling on our ancestors to help us. And to me, I think that brings people a lot of peace. I mean, I get lovely feedback from families that they just feel like, okay, this is the best way, you know, no one's happy about what happened, but this is the best way that it could have happened.
I think I'm running out of ink. I'm writing all of these tricks and tips down that you're giving us and our audience. That can't thank you enough. Like unbelievable. Yeah, it's great.
And one of the things I just want to say, like, just like to not be scared. Like I realized early on, like, the patients are looking to us as physicians to set the stage. You know, I remember when I was like a second year resident, I just totally, like, I still remember this man. I just totally connected with this man who had, you know, children like my age or a little younger. I think actually he was like his children were a little younger, and he was like my dad's age when he died. So I was like very connected to this man. And I was telling him he had like stage 4 cancer. And I said, like, how are you doing, or how are you feeling? And he's like, well, I don't know. Like, I've never gone through this before, you know? And I realized, like, our patients are really looking at us to be the guides, you know? And, you know, how many times have you been at the bedside of someone like who's been dying, and the family members are just standing there? Like, they don't know that they can touch their family members. I'm like, come on, gather around. Let's like love on this person and touch them and hug them and kiss them and put on some music. Like, they just don't know. They don't know because they've maybe never done it before. And so it's up to us to normalize all that and to really set the stage. And that's really the beginning of legacy, right? Because the patient's going to die regardless, but we're really in charge of how the family is that's the beginning of their processing of death. And we can really help them have kind of a good way forward, and hopefully avoid this complicated grief that a lot of us unfortunately struggle with.
Oh, that's beautifully and poetically said. And, you know, it makes me reflect on my own personal experience, which, you know, just briefly, was that my dad died quite young when I was in Atlanta training as a fellow. And it was interesting because he was an ex-professional hockey player who came from a farm and was a very salt of the earth kind of dude. And I would have bet, you know, $1 million times, you know, infinitely, essentially, that when his day came, he would have died very much like a salt of the earth guy, sort of saying, oh, well, this is part of life. Here we go. But he didn't. He was, you know, it happened very quickly over a couple of months, unexpectedly, but he railed against it. He was not happy. he felt he was too young, and all the other things that I'm sure you see every day. But that, for me, that was a really good lesson to what you're talking about with your example. We don't know how we would actually behave until we're in those situations, and we shouldn't make the assumption or project in any way from our experiences, whether it's job-based or whether it's just life-based, that we understand without asking some of these questions.
Right.
Very well said. The other thing I wanted to sort of dig down in with you is about, I don't know, just over a decade ago, we published a paper that looked at, I think it surveyed just over 500 clinicians in terms of how they look at end-of-life care in severely injured patients. And it was an international study, all 5 continents, all different types of trauma-related physicians. And it's interesting because that manuscript, that project, was spurred by a bunch of us as Canadians entering the US over about a 5-year period doing trauma and critical care fellowships and sensing a palpable difference in terms of how these 2 different cultures and countries looked at end-of-life care. And I'm curious what your thoughts are on Mira kind of touched on it a little bit there, but culture and country and religion sort of differences globally. And probably the most high profile example recently in this country, in Canada, has to do with medical assisted death and dying. That there's now a federal law that says we have to engage in this and have structures and systems in place to not necessarily promote it, but to do it with some sort of elegance and hopefully grace. I was curious what your thoughts are on all of that.
Well, so I just want to clarify, that's for the entire country that you guys have that?
Yeah, you betcha. It's a federal law. Yeah.
That's awesome. In the United States, I think there's about 8 states where physician-assisted suicide is currently legal. I think that religion certainly plays a great role in a lot of decisions that are made in this country, and I certainly see it in the South. There's a lot of and I'm Jewish, so I can't really even speak to it, but I just feel like there's a lot of religious beliefs that certainly rail against physician-assisted suicide the same way that they would rail against some abortion, say. But what I have found is that faith kind of works both ways, because they're the same people who really have this strong faith in God and will pray for a miracle. I find that a lot of people have just a lot of comfort in their religion and God, and feel like they know where their loved one is going. And so I tend to really try to support that idea and promote it. I have found that, say, for me, working in the South now, my language around death and dying has really, I've just kind of adopted the language that's around me. And to me, it still feels, it's not the language I was brought up with in New Jersey. It's not the language I would speak on the West Coast, but, to me, it's all the same. I really feel like we're all, whoever you're praying to, I mean, it's all, we're all looking for that same sense of comfort and support. And so I find myself kind of using that language of say, like Southern Baptist and that sort of thing. That's what a lot of our patients are down there, and talking a lot about God in a way that I wouldn't necessarily have talked about before. And just kind of reminding our families that, because this is what they believe, and I love this idea too, is that these patients will die and be fully healed. And so I think that's a great comfort for people. And so I echo it all the time. Your loved one is not going to suffer anymore. They're going to be fully healed. I say all the time that, it's us who's left behind that's going to be suffering. They're going to just go off into this eternal grace, basically. So that's how I've kind of found my way of that. That's how I've just kind of dealt with being in an environment that's not really native to me, but I still managed to make it work.
That's, I think, a beautiful reflection on this whole process and the real challenges of dealing with different cultures. I did want to touch briefly on your own podcast, and I'm curious what made you want to start that podcast in particular. And what have you sort of learned along the way from doing it? I'm curious what feedback people have given you and talked to you about and things like that.
Sure. So a little over a year ago at the in October of 2019, yes, at the American College of Surgeons Clinical Congress, the Committee on Surgical Palliative Care was meeting, and we were talking about how we really had the whole movement of surgical palliative care really didn't have any sort of online or social media presence. And so I initially started the Twitter account at Surge Pal Care. And then from that just started daydreaming about, okay, well, how do I I reflected a lot about when I started becoming interested in palliative care as a young surgical trainee. I really didn't have anywhere to turn. The American College of Surgeons had one online PDF that is called Surgical Palliative Care Residence Guide that was co-edited by Dr. Dunn. And that kind of became my Bible. I mean, that was like the one thing that I could use. And I certainly knew names like Dr. Jeffrey Dunn and Dr. Ann Mosenthal and Dr. Zara Cooper, but didn't necessarily feel empowered at that time to reaching out to them. And so I felt like, well, how do we make it so that this next generation of surgeons that, like you said, I think, I think more and more people and more surgeons are starting to consider talking about death and dying and suffering as part of their practice. And so how do I support this next generation of surgeons coming up? And, like many people, I love listening to podcasts. And I also felt very strongly, Dr. Dunn has been a great, he's like our historian, like he's written a lot about the history of surgical palliative care. But I was like, man, a lot of these people are old, like Dr. Mont is in his 80s. And if we don't record these people, they're going to die. And we're going to be so sad that we don't have their stories so that we can look back on them. And so I just felt really motivated, like this needs to happen. And I had the time and the energy. And so I'm like, this is going to happen now. It was very blessed to have Dr. Balfour-Mont as my first guest. I mean, I don't think you can get any better. And then Dr. Jeffrey Dunn, really, he's become a great mentor and friend of mine. And, his Rolodex is way deep. And so he's basically introduced me to a lot of people that I never would have been able to contact who agreed to be on the podcast. And then I got some advice from the folks who run the Jerry Powell podcast. And they kind of told me, cast a wide net, like don't just focus on surgeons and on physicians. And so then I started saying, oh, right, well, I need to have some nurses on and I just interviewed a pharmacist that hasn't come out yet and started looking at other people who aren't surgeons, like someone like Diane Meyer or Ira Byock, who are just giants in the field of palliative care, but have really, Dr. Byock, he really supported the surgical palliative care movement from the very beginning back in the late 90s. And so getting to talk to them and hearing what they thought surgeons brought to the field and also how surgeons might improve their communication. So I thought that was just really fascinating to get that input from them.
Do you ever get the sense that now surgeons, because you're making them sort of aware that there are ways of doing this better, do you get the sense sometimes that surgeons maybe are more scared to do their own sort of end of life care and are now referring everything to the palliative care team, and instead of really engaging with that themselves? And certainly, one of the challenges, as you pointed out, is that we really don't have time. And so I'm curious, what has been the feedback from surgeons listening to this? Has it been that, you've made me a lot better, I'm going to try and do this more myself? Or is it that, maybe I'm not the right person to do this? And sort of what are your thoughts on that?
So I think the feedback is mixed. Part of it depends on what field of surgery someone is in. So when I think of an acute care surgeon like myself, splitting time between the ICU and trauma floor and emergency general surgery, when I'm in the ICU, that kind of the general vibe of the ICU and kind of the rhythm of the ICU, that you're really in the ICU and not often in the operating room, it really lends itself to doing a lot of your own palliative care. And so there I try to do a lot of it. However, even for myself, even if I might want to, there are certain times when you can't. So one is, if your service is overflowing, you just can't. Two, I'm always mindful of who's following me in the ICU, because if I'm starting something that I sense is going to last like weeks rather than days, I will get the palliative care team involved, because that continuity of care is really hard. I have several partners who are very, very skilled at palliative care, and several who are like, they're just not as interested. And so, I really look to see who's coming next and if they're going to want to continue to engage on that level. And then lastly, when we do our own primary palliative care, we have to remember that, one of the, I think, selling points about palliative care is that it's an interdisciplinary team, right? So you have the physician, you'll have a nurse, you'll have an advanced practice provider, maybe you'll have a licensed clinical social worker, you can have a chaplain. If you're lucky, you'll have a pharmacist. Well, when I'm doing my own palliative care, you only have me. So it really depends on how much support the patient and the family and then the nurse needs. And I've talked about this before. There have been several cases. There's several cases that I'm thinking of where we've had young people with high spinal cord injuries, and I myself am so overwhelmed by the suffering that the patient and the family are going through. I find myself to be not very effective yet in those situations. But then the nurse is suffering and the family suffering, and there's just no way that one person can address all that suffering. And so for those kind of challenging cases, I will get the palliative care team involved, because they have a little more of the resources that are needed to take care of the family, to take care of the nurse, and of course to take care of the patient.
Yeah, there's a lot of emotional burden that you have to take on if you're suddenly the point person, and I'm sure you've become that for your colleagues, both in your own institution and nationally. It is not easy necessarily to keep on doing that day in and day out. And so how do you support yourself in that work?
Yeah. So one, I'm just super mindful about what my, how full my bucket feels basically. And on the days where it just doesn't feel full and I might have some stuff going on in my own life, then I'll just consult the palliative care team. And I'm very lucky. I work at the hospital where I did my palliative care fellowship. So I feel very comfortable just saying I'm just going through it today, or I'm just overwhelmed, either professionally or personally. And I just I'm so sorry I have to consult you, but I just I can't do this today. I'm very honest. And then I feel, I'm young in my career, but older in years. And I have now it feels like a lifetime, but over 2 decades of good self-care that's just programmed into me. So, thankfully I know how to sleep well. I know how to drink a lot of water. I know how to eat well. I know how to move my body almost every day. And so I know how to maintain a really good equilibrium. And then I think, I'm not the type of person or surgeon that just pretends that I know everything. I have no poker face. I'm very free with my emotions, and I just don't try to hide what I'm feeling. And so I don't waste a lot of energy trying to convince myself or you that I'm okay. If I'm going through something, I just kind of talk about it, and then, then it's out and I don't have to deal with it. And so not holding on to that idea of what a physician or a surgeon is supposed to look like, I think gives me a nice sense of freedom to just kind of move through my day and move through my life with a little more emotional freedom.
I hope we can all aspire to have that level of insight, because it's certainly not easy, and sometimes it takes a moment for you to kind of step back and say, whoa, what's going on? What do you say to the people who perhaps don't recognize or don't feel that is an important skill for them to have in terms of end-of-life care and palliative surgical care? We all know those people who are a bit brusque and perhaps don't think that this is what they need to be spending their time doing. And their time is better spent operating and curing people that they can cure. So how do you approach that colleague or that surgeon who maybe doesn't see the value the same way that you do?
Well, I think that everyone has their own skill set. I'm meant to do this, but I can think of people who are just meant to be in the OR for 15 hours a day, and that's probably the person I'd want operating on me if I had pancreatic cancer. So what I would just say to them is just, we all need as adults to recognize our strengths and our weaknesses. And if that, if communication is your quote unquote weakness, or if this kind of goal setting and end of life discussion is not really what you want to do, then can you please just recognize it and then consult the palliative care team? Because what stinks is these people who are not really great communicators, but who then won't consult the palliative care team. And so the patient's suffering and they have no one to talk to. But there's certainly people who are either too busy or just not engaged on that particular level. And I think that's fine. But then I strongly suggest I know, and it's not about saying, I know you're not good at this. It's more like, I know you're super busy and your plate's super full. Do you mind if we just consult palliative care on this patient? Because I really feel like they need that extra layer of support, and kind of just leave it at that.
That's a beautiful way to interact with that scenario. I should say we're not certainly unique in Calgary, but boy, oh boy, we have some pretty great relationships with our palliative care folks, both on the oncology side as well as on the trauma side, and we're grateful.
Yeah, palliative care teams are amazing. And that does speak to the other thing about palliative care teams. There's not enough palliative care physicians in the world. I mean, we know that when you look at the fellowship training spots every year. And so we do have to remember that they are a limited resource. So I do think that, yes, while I can forgive that surgeon who is, really meant to just be in the operating room and doesn't want to engage, at the same time, consulting palliative care, like established code status, is not appropriate. No, you are operating on the person, you establish the code status. Now if it gets hectic and they have all these unforeseen complications and all that, I of course 100% understand consulting palliative care, but we just have to remember that this team is a very, very limited resource, and we have to use them wisely. And I think that we've been seeing that so much in the last year throughout the world, that there's only so much of the palliative care team to go around with all this death and suffering that's happening. And so we all kind of have to step up. And, a lot of times it doesn't have to be this long drawn out discussion. A lot of times, again, as I was saying, people kind of know what's going on in their bodies. If we could hold a little space and a little time for them to just talk, a lot of times people can really tell you what they need if we just ask some of those very pointed questions.
Yeah, that's again beautifully said. There's no question. You're exactly right that nobody should show up in an operating room for a Klatskin resection or a Whipple without having had that discussion in a tempered, calm, quite potentially beautiful way in clinic before they arrive, for sure. I guess most importantly, we can't thank you enough for being on the podcast today. You're amazing. What you contribute is amazing, and you're changing the world clearly of surgery and beyond by doing what you do. So I hope you never stop. The last question we always ask almost everybody is, if you were to go backwards in time and give your younger self maybe some advice that the experienced sage self knows now, what would that be? What would you tell yourself?
I'd say, girl, you're enough. Keep shining bright. Keep showing up. I used to have a hard time showing up. Just show up. That's where the magic happens. I have found that in my life so much. So much magic has happened for me in the last couple of years because I've just shown up. I've just invited myself to the table. And then once you're there, people just assume you're supposed to be there. And then I wish I knew that when I was younger. I was always just so anxious, didn't want to step on toes, felt shy, and you just got to push through it, So I think that's what I'd say. And then there used to be a lot of angst around me in residency wearing glitter eyeshadow, which I never stopped wearing. So I tell myself it's okay to wear glitter eyeshadow. You're going to be just fine.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.